from the American Academy of Pediatrics.
Hi, everybody. Welcome to this special episode of Pediatrics on Call, the podcast on children's health and the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. Today we are coming to you live from Denver, Colorado at the AAP National Conference and Exhibition.
This is the 4th annual live recording of Pediatrics on Call, and the first time we have Dr. Andrea Cruz with us. She is the new deputy editor of the journal Pediatrics. Let's again give her a warm welcome like only pediatricians can.
All right, Joanna, I was really hoping, since you said a welcome only pediatricians can give, that someone was going to bring her a sticker.
Anyone have a sticker?
Does anyone have a sticker that they could give to
her
Dr.
eyes
Cruz?
light up.
People
I
are
will
looking
also take a
for
lollipop.
stickers. Yeah.
Exactly.
But that's a choking hazard.
Yeah, there you go.
Oh,
All right, we got stickers.
Someone,
We have
got
all
stickers.
Thank you. Welcome,
and
Andrea.
We might also want to give stickers, because we're fair around here, to the two other editors on stage. We have Dr. Alex Kemper, who is the new editor-in-chief of the journal, and Dr. Rachel Moon, associate editor of digital media.
Oh, I love these stickers. It says, I got my shots.
Yes. Oh,
To the
very
wonderful
timely.
pediatrician who just gave me this thing that I can't actually see without my reading glasses on, that is why I haven't put it on yet.
Well, because this is live, it is unedited and a little unhinged, but we are definitely going to make mistakes. So please just cheer us on when we do that. Your support always makes the final cut, and that is our favorite part of the entire recording, is hearing you. So thank you for joining us.
Yay. All right, Joanna, I love seeing you in real life instead of on my little computer screen in our little soundproofed closets. But speaking of sound, you can all be part of our audio team right now by silencing your mobile phones. And if you have a crinkly bag of chips or something, maybe just save that for afterwards. And we need to give a nod to the rest of our incredible audio team. We have our producer, Ann Johnsos, with us. And also down here, our audio engineer, Doug Nagel.
And one of our new producers, Claire Keating, is listening from home. So let's give a round of applause to Claire as well.
We miss you.
Okay, you know the drill. This episode is our chance to look at the hottest topics from this year in pediatrics.
Each of our editors has selected some of the most downloaded articles from the journal. Raise your hand if you're the person who clicked on a UTI article 100 times this year. They are not coming clean, Joanna. It seems like every year UTIs make a big splash. Must be the p-values.
Just go with the flow. Go with the flow.
Oh, okay. Bathroom jokes aside, and you would very well get along with my 5-year-old David. There is a UTI article on this list. Andrea, you are new here, but you have likely diagnosed a lot of UTIs as an emergency medicine doctor. What are the best ways for pediatricians to test for UTIs and counsel families on avoiding them?
Absolutely. So when we think about what you guys can do in the office, I think one of the really important things is knowing how well does a urine dipstick perform, right? And so when people have actually looked at this, and they've compared it to urine culture, and a study by Catherine Hunt and colleagues actually did this, and what they found was that if you compared it to what you can get if you send a urine off to the lab, that actually urine dipstick worked just as well as fancier modalities that you might not have access to in your office, and that would also be more costly to families. What they also found was that no matter what test you sent, somewhere between about 10 and 15% of the time, you might actually miss a urinary tract infection unless you send a backup urine culture. From a prevention strategy, it was a different paper that was out of Greece that actually looked at a systematic review looking at preventive strategies. And they actually looked at stuff like antibiotics, particularly Bactrim and nitrofurantoin, but they also looked at cranberry juice. And I admit, as a non-cranberry juice aficionado, I was really hoping that cranberry juice would not be valuable, and I was wrong, okay? And so what they actually found was, in terms of looking at prevention of UTIs, nitrofurantoin and cranberry juice were both actually fairly effective. Bactrim was not. However, when you looked at, was there any benefit to preventive strategies that extended beyond the period that you were actually using the product, then neither strategy actually decreased the risk of UTIs after you stopped taking it, nor did it decrease the risk of renal scarring. However, it does make me smile to think about, the company that makes Ocean Spray actually helping a different kind of spray potentially in our pediatric patients.
By the way, we are not hosted at all by Big Cranberry, so... Okay, so if we're going to talk about infectious diseases, RSV should definitely be the next pathogen we cover. Rachel, viral season is fast approaching, and it seems RSV always gets an invitation to that party. Is there a way we can offer a retraction to that invitation?
David, yes, there is. And the retraction is nirsevimab. And I actually have 3 articles that I want to share about nirsevimab. And as Andrea pointed out, and as several people today pointed out, depending on who the family is that you're talking about this with, you can either say, well, it's the RSV vaccine, or you can say, well, it actually isn't a vaccine. So depending on where your family lies in that, you can use either way. But 2 articles that I want to highlight looked at the effectiveness of nirsevimab against RSV-related morbidity in all infants. One came from the Kaiser Permanente Northern California group, Amber Shao and colleagues, and they looked at 32,000 infants, half of whom got nirsevimab. And then they looked at PCR, how many actually were RSV positive that following season. And they found that nirsevimab was 87% effective against lower respiratory tract infection, and it reduced any RSV diagnosis by 71%, and then reduced RSV hospitalizations by 98%. And then there was another article by David Martinez in Spain, and they did a retrospective study, and they had been using nirsevimab there since 2023. So they had different strategies across the country. Some who just gave it to those who were eligible at the time of RSV season starting. Some of them who, then they also caught up some in certain districts. So some districts immunized those who were less than 3 months old at the onset of the season, and some also immunized those who were younger than 6 months old at the beginning of the season. And basically what they found was that it did work. For hospitalizations, for lower tract respiratory infections, and that the improvement in outcome was better the more babies you immunized. So that was really great. And then the final study I just want to highlight is by Joseph Demikowski and colleagues who looked at nirsevimab in young children who had immunocompromise. And this was a phase 2 open-label, single-dose, uncontrolled study of 122 children who were younger than 2 years of age from 8 different countries. And they found that nirsevimab was safe. There were no serious side effects. It was extremely effective. There were 0 RSV lower respiratory tract infections that needed medical attention. The serum concentrations of antibodies were similar to those in healthy infants. So we'll just give nirsevimab to everybody.
Woo, I love that. All right, if our brains were muscles, then we have done a warm-up and we're ready to hit the treadmill. Alex, are you a runner?
Well, after reading the systematic review on the benefit of exercise and intelligence, maybe I should have been, but I think I missed my window.
Do we have any runners in the room? Anyone who's... Woo.
All right.
All right.
You all are smarter than me. So we published a systematic review this year by Javier Morales and colleagues from Spain that looked at randomized trials of exercise and how that affected intelligence. And As it turns out, there was a small but positive impact there, that it was associated with 4 IQ points. Now, it's a little hard to interpret the studies and compare them because the kinds of exercise that were involved were fairly heterogeneous, and how they measured intelligence varied across studies as well. But it's sort of amazing that was found there. And again, this is a trial, so it gets rid of the issues of confounding, because maybe people with higher intelligence like to exercise in the first place. But this is a trial, so that's not the case. So, my guess is that there are probably other benefits from exercise, or at least I've heard that from other people who do that kind of thing. I personally believe that I have a fixed number of heartbeats, and I don't want to push things too much. But it does seem like there's a benefit there. We also published a couple of other interesting studies addressing obesity. It's hard in the primary care setting to treat obesity, especially with the guidelines that you try to get 26 contact hours with patients and their families. And so we published a randomized trial that looked at whether or not referring patients and partnering with Parks and Recs departments in addition to usual care improved outcomes. This was a study that was done by Sarah Armstrong and colleagues at Duke University. And the bottom line is, over the 6-month period of time, there was a significant benefit for patients with obesity. Now, it was a little complicated. They didn't get to most of the children didn't get to 26 hours of contact time, and you might remember the year 2020. There's something that happened there. A little pandemic came up, and so the pandemic certainly did not help the patients that were in the trial. But now that we're out of the pandemic, if you look to the part of the study that was during the pre-pandemic time, there's no question that there was benefit. So I'm just wondering, how many people partner with Parks and Rec to treat obesity? Does anybody do that? All right, so for those of you listening, everybody in the room raise their hand. It's something to think about. It's really an effective intervention. We also published a study that looked at going to the patient's house to deliver interventions compared to usual care for children and teens who were at the 85th percentile or more. This was another trial that was done in Chicago by Dr. Appelines and colleagues. And they found a benefit there. It was kind of a small benefit, but it shows that there are these things out there, and thinking about the resources that you have available in your community, you can really come up with innovative approaches that, based on the evidence we have, are effective. So there are lots of things to think about.
Alex, do we know if the benefits extend to people who just watch reruns of Parks and Rec?
I'm actually counting on that. I've applied to the NIH to test that hypothesis, and I'm waiting to hear back from the study section.
All right. Keep us posted.
I will definitely let you know.
Andrea, throughout my career as a general pediatrician and pediatric hospitalist, I have seen so much change in how we manage infants who are exposed to opioids in utero, from Finnegan scoring to Eat, Sleep, Console, but it still seems like all roads lead to pharmacotherapy with morphine. Can you give us an off-ramp?
I can. So one of the things that we think about is, while severe neonatal opioid withdrawal syndrome has classically been defined as needing oral morphine, there's a recent study that was done out of University of Kentucky and out of Cincinnati Children's Hospital and out of UT Memphis that actually looks at, does oral clonidine work? Right? And the idea is that oral clonidine is a non-opioid alpha-2 agonist. And would it work just as well as oral morphine to help with the symptomatology in these children? So what they did was the investigators looked at a cohort of 120 children who met the Finnegan criteria, so they used the Finnegan for this one, for severe neonatal opioid withdrawal syndrome, and they randomized them 1-to-1 to get either morphine or to get oral clonidine. And what they then did was they looked at 3 classes of outcomes. The first class of outcomes that they looked at were neurodevelopmental and behavioral outcomes. Then they also looked at how long did the kids require treatment, and did they need breakthrough treatment aside from the baseline either morphine or oral clonidine that they got randomized to. And I'm going to start with what I think is the most important outcome, which is the neurodevelopmental piece. And they did a battery of testing on these children, and what they found was that there was no difference in neurodevelopmental outcomes for children who got morphine versus those who got clonidine. Then they looked at how long did the kids need to be treated, and it was on the order of 2.5 weeks, and that was no different between the two groups. And lastly, what they looked at were the percent of children who needed breakthrough medications because they had symptoms that were withdrawal symptoms that were starting to occur before their next scheduled dose. And that actually was higher for children who received clonidine. And with the investigators suggesting that maybe the issue is not the clonidine, is that we need more information about what is the right dose or what is the right dosing interval to use for these children.
And David is further out of training than I am, but just as he was talking about changes and how we treat babies, I see changes in how we are raising the next generation of pediatricians. Alex, how did the journal acknowledge and summarize the changes in pediatric training we're seeing in 2025?
So let me back up first by saying it's critical that we recruit medical students into pediatrics. And of course, who can think of a better job? But we also have this looming subspecialty workforce challenge, right? So in a lot of communities, the full range of subspecialists just is not available for children and adolescents who need medical care. And so we published a lot of articles in the past year, both looking at the workforce and also looking at issues of training like you talked about, and they kind of fit together hand in glove. So we published one study that was a survey of residency program directors that looked at how often are residents moved on who maybe are not exactly there in terms of their level of ability. And this was a study that was done by Daniel Schumacher, who's at Cincinnati Children's Hospital, and a bunch of other colleagues nationally. And they describe that it does occasionally happen, and some of the reasons that it happens because there's disagreement between the residency program director and the clinical competency committees about whether or not they're able to move the, I almost said the patient, but the trainee forward. But there are a lot of other complications that go in there. And one of the things that this study points out, and this is going to be a theme in some of the other studies I want to mention briefly, is that traditionally we look at whether or not a trainee is competent and ready to provide care based on how well they do on some sort of standardized examination like the board exam that we take or the in-training examinations that happen during residency training program. There is a big move, and the American Board of Pediatrics has been a leader with this in looking at competency-based medical education. So instead of looking at whether or not, you can answer some question about the Krebs cycle, can you actually coordinate care? Can you provide the kind of services that patients need? Those are called entrustable professional activities, or I've also heard them referred to as everyday pediatric activities. And there's a whole laundry list of them. And there's a movement now to help residency programs use those, as well as fellowship programs to use those. So we also looked at two other studies about whether or not fellows are prepared to graduate in general. As with the study about residents, there are questions about whether or not they're ready. And one of the studies in particular that I wanted to mention was by Dr. Sarah Pitts and colleagues that points out that there's this debate right now about whether fellowship programs should be done in 2 years versus 3 years, because with the workforce shortage, if you could get people out in 2 years versus 3 years, then you could build up the workforce faster. And if you look at these entrustable professional activities across the broad range of subspecialists, in general, fellows are not ready after 2 years versus 3 years. Now, the caveat, of course, is that these fellowship programs are not designed to happen in 2 years versus 3 years. So we can't just, cut off a year and kind of condense things and hope that things will work out without putting a ton of resources and really think about things from a educational standpoint about being able to prepare fellows to complete in 2 years. So I think that in the coming years, we're going to see a lot of work about how we can make sure that pediatricians, as they go into practice, are ready to provide the kind of care that patients and families want. And also, what are the novel opportunities to be able to train fellows better so that they can, be ready to practice perhaps in 2 years versus 3 years. I can say that as a journal, we're really committed to expanding the amount of educational work that we publish. So how many people are educators? Okay, everybody raise their hand again. It's amazing. But we really want to get your work, and we think that this is an important conversation that our field needs to have.
Well, we were just talking about supporting the development of our pediatric learners, but let's take it back a few years. Rachel, when children need extra support for their development, how can we help coordinate that for them?
It's tricky, isn't it? I mean, a lot of us don't have people who can help with this. And even though we know that early intervention, and the earlier the better, has really great outcomes for children, only 10% of those who are eligible for early intervention receive it by their second birthday. So Dr. Bergen Nelson from Virginia Commonwealth University and her colleagues from UCLA and USC, they did this really great thing. So they used the 211 system. Does anybody know what anybody used the 211 system before? Yeah. So 211 is available almost everywhere in the U.S., and it's where you can call to find out, get information about resources. So they used this 211 system, and they trained early childhood care coordinators who worked for that system. And then they randomized children, young children, 12 to 42 months, did developmental screenings on them during their well-child visits, and then they were randomized to either get usual care from their from their pediatrician or their provider, or regular well-child care plus a telephone connection to an early childhood specialist at 211 LA. And the 211 LA specialist would talk about the screening results, and then based on the baby's age, the child's age, their developmental risk, and their family eligibility, referred the family to early intervention services, and then they followed up with them. So just think about this. So number one, you call a number and they answer and they're helpful, and then they call you back to make sure that you got what you needed. I mean, this is remarkable. It shouldn't be, but it is. So what happened? So maybe not surprisingly, but the children who were connected to 211 were more likely to be referred to services. They were more likely to be enrolled in services, and particularly those with moderate or high developmental risk, they did even better. And then here's a spoiler. Next week, there's going to be a follow-up article about this program in Pediatrics that's being early released, and you'll want to read that. But I think it's really exciting that we can use existing infrastructure, and this is a creative way of doing that to try to get resources to families and to children who need it most.
I think this is the first time we've ended with a cliffhanger.
Maybe. There's always a first.
Yeah.
So season 2.
Yeah, I'll be reading the journal next week.
Yeah.
And as children grow and they develop, they become teenagers, and the pressure to push boundaries and experiment grows. Sometimes that leads adolescents to smoking, vaping, or other drugs. Andrea, what substances are children turning to today, and how can we help them funnel their curiosity in healthier directions?
It's a great question. So one of the things that kids are doing is they're doing a lot of vaping, right? This comes as a surprise to no one. And so there was a study actually by Megan Patrick and colleagues at the University of Michigan that looked at what were the reasons behind why kids were vaping. And they focused on vaping nicotine products, right? Not all the stuff that you can buy legally in Colorado if you're of the age of majority. And what they did was they actually did this through a survey-based format. And they interviewed kids they surveyed children who were in 8th grade, 10th grade, and 12th grade. And this is not surprising. The percent of kids who reported almost daily vaping went from 2% in the 8th graders all the way up to 8% by the time the children were high school seniors. And then actually, I thought this was really intriguing. They asked them why. Why did you choose to vape? And what they did was they then compared it to a study that was done in 2015, where one of the most common reasons to vape was because they like the taste. Right? So now as there's been a crackdown on not, having like watermelon flavored and cotton candy flavor and other disgusting flavors that are clearly targeting an audience that is the adolescent crowd, the reasons for why kids vape has shifted. And now the most common reason is actually kids are vaping because they say it helps them relax. They also say that it's because they want to experiment, which is not surprising in this age group developmentally. And then they also point out a lot of times they vape because they're bored. And I must have just been an incredibly boring child, because when I was bored as a kid, I think if I'd vaped, my mother probably would have killed me. But those are the most common reason that kids are vaping now. And I think one of the other things that we think about as we think about substance use in children, a lot of times we think about the substances kids acquire themselves. And I think we also have to take some ownership over things that patients get from us. And so there's a new clinical practice guideline by Scott Hadlin and colleagues that was released at the end of last year that is incredibly helpful because Scott and his colleagues talk about the do's and don'ts of prescribing opioids. Right? Because I think many times as clinicians, we feel like we're walking this tightrope between we want to make sure we treat our patients' pain, but we don't want to increase their risk of substance use later on. And so the do's that they talk about include things like you want to start off with the lowest possible dose. You want to give no more than 5 days of medications. You want to make sure you ask about use of other sedating medications like melatonin, for example, which is, I had no idea melatonin was so widely used by families to help their children sleep. They also say that you should never give just an opioid. It should always be paired with an NSAID or the dreaded acetaminophen, okay? They talk about not using tramadol and codeine in younger children, prepubertal children, and not to use it in children who have had tonsillectomy and adenoidectomy because they already have risk factors for upper airway obstruction. So I think it's a really practical guideline, and it also touches on use of Narcan. Right? So while it has been recommended that we talk to our patients about naloxone if we're giving them opioid prescriptions, the new clinical practice guidelines actually say that we should be dispensing Narcan along with the opioid prescription. Right? And certainly families can get it over the counter, but it's an important conversation that we need to integrate into our pain management conversations with our families.
Well, speaking of pain, raise your hand if you've heard any misinformation or disinformation about autism in the last week. All right, the hands really are up this time.
Yeah,
it's pretty much everybody. We know autism is largely genetic, and the concept of a cure can be actually stigmatizing and insulting to those who have autism spectrum disorder. Alex, what actual evidence emerged this year to help us serve these children and their families?
I want to highlight two studies. The first is a study that looked at the overlap between children with medical complexity and autism. So there are different definitions for what a child with medical complexity is, but you can think of these as children who have significant health impairing conditions that affect 2 or more organ systems. So there are a lot of things that fall into it. It's a heterogeneous population, but it's also a very complex population. And in this study by Dr. Philip Smith, who's at Drexel, they used 2 different national data sets to try to estimate what the overlap is between children with medical complexity and autism. And they found that depending upon how you looked at it and exactly which population of children with medical complexity that you looked at, upwards of 40% or more of children with medical complexity have autism. And that's important to remember for a number of different reasons. One is when you, as a clinician, are addressing all the needs of a child with medical complexity, it's easy to forget about developmental screening and screening for autism. So this for me was a good reminder, and I just wonder if that large estimate that I gave actually is an underestimate, because it would be easy to miss autism in those patients. And this study also talks about here's no surprise to anybody how fragmented the system is for children with medical complexity. And then when you overlay the issues of autism, just how challenging that really is for families. And I think it's a call to action for pediatricians. One thing that I want to also say about this study, which I think is really important, is that included in the authorship list was a student and also a family advocate for autism. And as a journal, we are really looking for studies that show those collaborations between us and the medical world and families and people with lived experiences. And some of you may know that over the past few years, we developed a whole section called Family Partnerships that show how families can work with clinicians to solve problems. And they're really inspiring to read because they have lessons in there that we can all adopt. And so related to that, I just wanted to talk about another review that we published. This one was by Dr. Lee, who did this study in China, but it's a systematic review of family navigation programs for children with autism. And they found a whole bunch of different studies, all using different approaches for family navigation. And by and large, all of those programs helped reduce the fragmentation, improved health outcomes for patients and families. I like this study a lot because I think of it as the Happy Meal collection of all the different ways that you can work with families to get family navigation into place. So you can kind of look at it and see, like what local resources you have and what might help those families. But I think that there are a lot of lessons in there.
And one thing we know is vaccines do not cause autism. Vaccines do cause healthy young adults. Rachel, can you give us some updates on vaccines and how well they teach our children's immune systems?
I want to highlight 3 different studies on 3 different vaccines. One is looking at the risk of transmission of rotavirus vaccine, vaccine strain rotavirus in a NICU setting. And this came from Children's Hospital of Philadelphia NICU. And so, Joanna, you may have been part of this study. As you know, that we often do not give live vaccines in the hospital setting because we're worried that it could potentially infect people around them that are immunocompromised. So sometimes we'll vaccinate them on their way out the door, or sometimes we just let the primary care provider vaccinate them. But what they did at CHOP, I think this was a remarkable study. So over the course of the year, they gave the rotavirus vaccine to NICU babies beginning at 2 months and following the what used to be the CDC guidelines. And they used the RV5 rotavirus vaccine, so that was Rotatech. And then I can't believe, but they collected stool samples every week for RV5 testing from every single patient in the NICU. And then if any of the samples were positive, then they looked at who was around those babies and where they might have gotten the infection. So they gave rotavirus vaccine to 162 patients, and there was indeed shedding. So about 70% of people who got the rotavirus vaccine shed after 1 week, and it was about 40% after the second week. Fewer than 1% of the babies that were unvaccinated had virus-positive stools, and 4 of those had shared a healthcare team member with a recently vaccinated patient. But none of those patients who were positive for rotavirus had clinical symptoms. So even though shedding does occur, transmission is very rare, and it has no apparent clinical consequences for these babies. So maybe we need to think about updating our policies about that. I do want to caveat that this study only used the Rotatech virus vaccine. It did not use the Rotarix, and there may be differences there, but in any case, I think that that's a great take-home that it's safe to use. The second one, also having to do with safety, is looking at live attenuated influenza vaccine for children who have asthma or a history of wheezing. And so Alan Bandel, who is a pharmacist, did a systematic review of patients with asthma, and as you know, there are two types of influenza vaccines. So there's a live attenuated, which is given intranasally, and then there's an inactivated one, which is given by injection. And we all know that if it's not a needle, then that might be more attractive for families and for children, and particularly children who have a history of asthma and wheezing may have a higher risk or do have a higher risk of severe infection when they get influenza. So the authors did a systematic review of 24 studies that looked at the safety of the live attenuated influenza vaccine for those who were between 2 and 49 years of age who had either asthma or recurrent wheezing. And what they found was that there was little or no difference in patient-reported outcomes if you got the intranasal versus the inactivated vaccine or no vaccine. So this may potentially increase the vaccine options for patients with asthma or recurrent wheeze. And then I just want to note that this year the FDA has approved the intranasal vaccine for at-home use. And if you travel in the exhibit hall, you might actually see some people who are selling that. But that is something that is important to know and that families may ask you about as well. And the last study that I want to mention is about COVID vaccine. Does it matter if the mom gets a COVID vaccine during pregnancy or after delivery? And this is a question that I still get a lot from people, and actually our daughter's friends are many of them who are pregnant are asking me this as well. So what is better? Because we do want the babies to have antibodies for the first 6 months until they can get the COVID vaccine. So Flora Muniz from Baylor College of Medicine, they looked at this and they enrolled a prospective cohort of infants, and there were 3 different groups of mothers: one who got 2 doses of COVID vaccine during pregnancy, ones who got 3 doses of vaccine either before or during pregnancy, and those mothers were considered to be boosted. And the mothers who did not get the vaccine during pregnancy but got it right after pregnancy, right after delivery, and then got the last dose at least 2 weeks before the baby's 2-month visit. And then they measured antibody titers in the mothers and then in the babies at 0, 2, and 6 months. And so what they found was that those who were born to mothers who had gotten the 3 doses had the highest levels of antibodies at all 3 time points. And also, they were the only ones who had antibody levels at 6 months. Those who had, whose mothers got 2 doses, they had levels at 0 and 2 months, but not at 6 months. And then, and both of those were actually much better than if the mother got the vaccine after the baby was delivered. So, the other thing that was important was that if the mother had COVID infection during pregnancy, or if the baby had infection during the first 6 months of life, or if the later in pregnancy that the mother got the last vaccine, the antibodies were higher. Whether the baby was breastfed or formula fed did not make a difference, and so this study supports giving the pregnant mothers the COVID vaccine during pregnancy and not waiting until after birth and depending on the breast milk antibodies to protect the babies.
I really appreciate that. I see some people out here are taking notes, and I think we can all agree that documentation is one of the most frustrating, but also among the most important parts of our practice. Alex, should we be leveraging AI more in our documentation? And if we do that, how can we do it without introducing errors?
We have published so much stuff about AI in the past year or two. I had to say, before that, I couldn't even spell AI. But we've learned a lot of things in terms of what works well and what doesn't. So we have so many studies that I can pick from. I'm just going to highlight a few. So one was a study where they looked at using ChatGPT to provide patient-specific answers to parents' questions in the PICU. This was done by Brendan Hunter and colleagues at Baylor. And in this case, they uploaded a whole bunch of example admission notes and those kinds of things, and then they just tried to essentially break it with a bunch of questions that parents might ask, and it worked well. You know, that there were no significant inaccuracies. It did require some editing, but in general, it worked well. Now, there are lots of caveats about using AI for these kinds of things, you know, in terms of hallucinations and just having downright errors. So you need to be careful about it. I'm not giving this like wholesale endorsement that we can all, you know, sit at home and eat bonbons and hope that AI is going to do the communication with families, you know, still including family center rounds and engaging with families is just really critical. But I also have no doubt that these tools are going to get better over time, and this is going to help facilitate things for families. I want to highlight another example, though, of using AI and large language models in ways that people might not think about, but can really help to improve your quality. So, you know, everybody's engaged in quality improvement, and quality improvement can be really challenging because you have to go through so many charts to figure out what's going on. And so we published a study looking at whether or not you can use large language models to audit charts. In this case, they were looking at whether or not patients who were prescribed medications for ADHD had a subsequent visit where side effects were assessed and documented. And the particular QI results are less important than the fact that they could successfully use AI to go through a huge number of charts with very little things that they had to overcome to be able to do it. And I really think that all of us are going to see more quality improvement activities coming this way. Actually, I forgot to give credit to the folks that did this. The lead author was Dr. Yara Bennett, who is somewhere. It's at Stanford. Yeah. You can see I had to make a mistake somewhere, but they can. The great thing about this is they can edit that. So, Dr. Yara Bennett at Stanford.
Oh no, there's not going to be editing.
Exactly.
It's in.
So, I think that's pretty cool. And, you know, so much quality improvement right now is based on things that are easy to audit in terms of claim stuff and those kinds of things. But it's hard to get to more granular, meaningful patient-level outcomes. And I can really see this as a role for AI. So, you know, we certainly did, David, as you alluded to, publish a lot of material about how AI can help us with patient communication. But I think that there are these novel and more creative uses of AI that we're going to increasingly see in the future. So I'm pretty excited about that.
Let's go from AI to DEI, diversity, equity, and inclusion, are words that should be celebrated and goals we all strive for. So, Andrea, how has the American Academy of Pediatrics worked to ensure, as an organization, it embraces DEI?
It's a great question. I think this is something that is critically important that we do as a professional society, as clinicians, and we really feel that this is something that we want to continue to support at the journal as well. We actually have a section on DEI in pediatrics, and I wanted to highlight a couple of the articles that we have published in the last year, really spanning the pediatric age range, that really talk about DEI issues that affect our patients of all ages. And the first is actually a study by Corey McDaniel and colleagues that used a database called REVISE, which stands for Reducing Excessive Variation in infant sepsis evaluations. And they looked at a cohort of 17,000 infants across 99 hospitals. So this wasn't that this was, a handpicked number of hospitals. This is a pretty wide representation of where children receive care. And they wanted to address a specific question, which is what happened after the implementation of the 2021 febrile infant practice guidelines. So often when a practice guideline is implemented, you notice that there's a decrease in variation because we all tend to be doing the same thing as we're presented with a sort of a critical body of evidence. And what they actually found was disturbing. What they found was before the guideline, people were all over the map in terms of what they were doing for febrile babies, which as a neonatologist, I'm sure makes you cringe. But what they found was after the guideline became integrated into practice, that actually disparities emerged. And what they found was when you looked at non-Hispanic white infants, they were more likely to get inflammatory markers done. When you looked at Hispanic and Black infants, there was less likely to be documentation of shared decision-making. And I don't think that's going to be fixable by AI, right? And furthermore, for Hispanic infants, there was less documentation, there was less often obtaining inflammatory markers, and also there was less documentation of what follow-up was to happen after the children left the emergency department. So clearly having a guideline alone will not, as a standalone option, actually remove disparities in care. And I want to contrast this to a study that was done in adolescents. And this title was about the adultification of young Black females. And what they did was, this was a collaboration between an adolescent health group at the University of Pittsburgh, and the first author on this paper was Daniela Brissett. And it was actually paired with a community-based organization in Pittsburgh. And what they did was they interviewed 13 to 24-year-old Black adolescents and young adults, and also their female caregivers. And they asked them about this concept of adultification, which is that when we have a tendency to view children as older than their chronological age, we tend to impose on them the behavioral and maturity expectations of an older child. So if any of you have tall children, this is not a problem in my family, but you might notice that sometimes even something just like stature, people have a tendency to perceive a tall kid as being older and therefore expect them to be more mature, when in fact the kid is totally mature for their chronological age. And so when they interviewed the girls, several themes came out. The girls talked about how they really wanted to be afforded the innocence of childhood. They felt that society was making them grow up too fast because there was this perception that they were older than they in fact were. And from the standpoint of the caregivers, they felt like they were really unprepared for this concept of adultification when they were counseling their child. That they really worried about their children being criminalized in the school system because the expectations that they had were not concordant with a child's chronological age. And they really worried about the impact of this on the children's mental health. So I think that, we are clearly not there yet in terms of having equitable care for all the children that we provide care for. And we know we're not there yet, but we're also not going to stick our head in the sand and act like by not exploring these and identifying the gaps, that is somehow going to cover up a problem that exists, right? We need to know where these disparities exist, because then we can work toward, as a group, closing those. And we realize as clinicians, we're not going to be able to do this alone. We need our families to participate in this process. We need our clinicians. We need our nursing partners and our hospital-based partners or our practice-based partners for those of you in private practice. And we also need to have our researchers and our policymakers engaged in this. And it's only as coming together as a community that we're actually able to get to that ultimate goal of providing equitable care.
Well, that is a goal we definitely need to keep our eyes on. I have a more superficial goal. Rachel, you may not guess this, but a lot of my social media followers are fascinated by my skincare routine. They want to know what they should avoid.
Your skin is quite lovely, David.
Thank you. So how are today's youth maintaining that youthful appearance?
Are you getting your skincare routine from TikTok?
They're getting their skincare routine from my TikTok. I'm getting my skincare routine from the discount bin at Harris Teeter.
There you go. Okay. Okay. Well, a lot of kids are getting their information about skincare on TikTok. So there is this interesting article by Molly Hales and colleagues from Northwestern University that they wanted to look at these TikTok skincare regimens, and they wanted to see if they would be appropriate for children, the ones that are the target audience for this. So two of the authors created new TikTok accounts saying that they were 13 years or younger. And then they used the tabs there to find what content was recommended by TikTok. And when they found when they got a skincare regimen, then they would click on it to like it, and then they saved it. And then, of course, that made the algorithm send them more and more and more until they had accumulated 100 of these videos. These were 100 videos from 82 different content creators. 1/3 of them were created by children who are 13 years and younger. In the 100 videos, there were 260 products featured, with an average of 6 products per video, and costing an average of $160, but up to $620 per regimen. Some of these regimens were super, super complicated and time-consuming, and some of the girls, it was mostly girls that were creating these videos. They would talk about waking up at 4:30 in the morning to start their skincare regimen before they got to school. Only a quarter of them included sunscreen, which is probably the one thing that they needed to have in them. And there were a lot of active ingredients that were irritants, that were known irritants, or known culprits for contact allergens. So I bring this up because I think it's important for us to know that these things are out there, and that our families and our children are potentially buying into these, and that they may not be. They're certainly expensive, they're certainly time-consuming, they may not be helpful, and they may be harmful.
Well, speaking of social media, even though we're a podcast and mostly audio, we do have a camera here, and I'd love to hear everybody cheer for the editors of Pediatrics, Dr. Cruz, Dr. Kemper, and Dr. Moon, who just covered 12 topics in this session. Thank you guys so much.
That is really impressive, and with no edits. That is it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. And join us next week when we'll focus on our favorite moments from the National Conference and Exhibition.
We'll talk about what we learned and ways to access even more content online. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.
Joanna, is your favorite moment going to be replaying the podcast again?
Yes, I'm only going to talk about this session in another podcast. It's very meta.